Computer. All right, this is pause. Okay, so we are recording. Welcome. So this week we're going to talk about interventions and what common early pregnancy tests and like most of the time when you go in and they'll say, okay, you know, we're going to do this at this time, we're going to do this at this time, and sort of what they mean. You may or may not have had some of these yet. The first one is group B strep. Have you heard of group B strep?
Heard of it, yes.
Heard of it? Okay, so that's, you know, how you have naturally occurring microbiome. And so group B strep is one of the bacteria that they test for. And essentially what they do is they take a swab and they swab the inside of your vagina. And sometimes they go down towards your anus and then they culture it. And you have a return. Typically they'll either say it's positive or it's negative. But then there's also kind of a range in between there of if it's positive enough to bring back a culture, or if it's positive enough to be considered colonized, or if it's just showing up as there but is not, I can't remember what the word they use is, but a plethora of the bacteria.
Okay.
And so what that does is if you come back and it says, and you guys' situation will be a little different because you have a home birth, but if you're positive for group B strep, the typical antidote is antibiotics. And they do an IV antibiotics every 4 hours in labor, and they administer that continuously while you're there. Midwives, I do believe, have an antibiotic regimen. Some also have like a topical regimen. So I know some use like topical tea tree, or I've actually never been treated for a group B strep by a midwife, so it just depends on what their regimen is. So the antibiotics go through the placenta to the baby if you do get an IV. And so why would you, the risks of group B strep, the risk of group B strep is infection of the baby, and that can do things like fever, and they turn around and have the infection that can then lead to, you know, more complications for the infant. But you can also decline the test. And why would you do that? Because the risk is low. So there's an article, right, I think I put it in here. Evidence-based birth, have you guys had a chance to check out that website? Yeah, it's a good one. So I don't think I included it this week in your handouts. I don't know that I turned the air on. But this is the one that they have on their website. But okay, so positive or negative for group B strep is typically the answer you'll get, and that's around 35 weeks is when they do the test. And positive doesn't necessarily mean that you have to have antibiotics. It doesn't mean that it's the end of, you know, you're positive. You can change some of the things you can do to prevent coming up positive on group B strep are probiotics and live yogurt and kefir and what's it called, kombucha. All of your live culture, garlic, all of these things include in your diet, sauerkraut, all that kind of stuff.
Yeah.
Up your probiotics, and you're likely to have not a positive group B strep. So the risk to baby is, and also for this week at the end of the packet, you have I guess it's the third page. You have a piece of paper that's got just a bunch of blanks on it. And I put this in here because I want you to be active as far as filling out like benefits, risks, alternatives, intuition, and nothing. So anytime, if you want to do this now, if you want to go back later and try and fill it in and then come back with questions, doesn't matter to me how you do it, but it's just a good way to kind of have a bigger picture of all of the different things we're going to talk about.
Okay, yeah.
So GBS at the top is group B strep. For the empty class there online, some of them will be watching this later. So the main disadvantage of a group B strep, so one of the risks would be that if you're found to be a carrier, you typically in the hospital, they'll say it's our policy that you have to be on antibiotics. So, or have labor-induced. One of the disadvantages of being on antibiotics, if you've ever gone in and taken antibiotics, how's it going? Cool. Is it kills all the good stuff and bad stuff, right? So that can kind of give you jumpstart. And I wouldn't want a baby to start their life out on antibiotics. If you think about what that does to your microbiome, it's nothing basically at that point. So it kills everything they start with. So it's, you talk to your care provider and see, once you get that test result back, what can I do to, what is your regimen for group B strep? Do you test? With midwives, you can decline. A lot of times what they do is they'll say, if you don't take the group B strep test, we're going to watch your baby for signs of infection. If there are no signs of infection, we don't treat. If there are signs of infection, then you go with the antibiotics. Any questions?
What was the signs of infection with the baby?
Fever usually is the first sign. And then beyond that, I'm not sure because I don't usually do the medical side of it.
Like a cold of some sort?
So the group B strep infection, you know what strep is. Mm-hmm. So essentially in a baby that young, what happens is you have the risk of meningitis, of the spinal infection and brain swelling and all of that is much higher even for not so serious infections, because it can become, especially if they don't have antibiotics, it can become, they're so susceptible to things like that can become a problem more quickly. But they usually will watch for the first 24 hours. So if baby is not got a fever, is feeding normally, is still, the temperature is regulated, they're not excessively sleepy or tired, usually there's not any concern. And your midwife will come back and visit you within 24 hours typically, or within 2 days. And then if you were to test positive, she would either talk to you about the regimen, what she does, and then, tell you what to watch for if you were declining the antibiotics.
Yeah.
So as far as for the hospital, one thing that they can do is connect the IV, and then they disconnect the IV after antibiotics are given, and then they'll connect it again for the antibiotics, and then disconnect it. So it's not a big deal. You don't necessarily have to be tied to your IV. The next one is blood glucose. So do you know what blood glucose tests for? Gestational diabetes. The test is typically an overload of sugar. So I think it's like 50 grams of sugar. And you can either do, they have like the blood glucose drink. With midwives, you're usually much more flexible. You can do jelly beans or apple juice or something like that. Or some of them will just say, go eat a pancake breakfast before you come in. It used to be that they made you fast. You couldn't eat from midnight the night before until you came into a doctor, and then you had to drink this nasty drink. But a lot more women these days are saying, no, I'm not doing that. And so they've started to slowly kind of change. This is one that we're seeing a little bit of change on. But like I know at Princeton, you could go do 2/3 of a cup of apple juice, and they don't necessarily require you to fast from midnight the night before. Yes, it can be real sick feeling as a pregnant person not to eat and then have an overload of sugar. Right? It's just like, that's rude. So, and then you wait for an hour, and then they test your blood sugar. And if your blood sugar is within the normal range, your body can still process sugars effectively. If your blood sugar is not within the normal range, it's still really high and it's not being managed properly, then you come back in for a 3-hour test. And they basically do the same thing. This is my partner, Esteban. Hi. Yeah, kind of. Okay. This is Amy Doe and JJ.
Hey, how's it going?
What's up?
Lovely.
Okay. Yeah, no, it's okay. Babies are at home. Everyone that watches it knows you. Clint and Deanna said they were coming by.
Here?
No, the house. They're at the shop right now. Yeah, you should. Okay, love you. Bye. He's been here working since like 8:30 this morning. Yes, on the playground. So blood glucose. So you come back for a 3-hour if your blood sugar is not within normal, and then they treat it however they see fit. Usually it's either insulin, or I know someone who's managed it with diet. just one of those things. If you always have the option to decline if you don't have diabetes in your family. However, there's really no predictors for gestational diabetes besides being pregnant. So unfortunately, it's just one of those tests that it gives you a lot of good information. The trick with this one is, what do you want to take? What do you want to be your sugar substance? That glucose drink is nasty. So I don't recommend it. And then with the blood glucose, so the risks of gestational diabetes include big baby, low blood sugar at birth, and problems regulating temperature when the baby's born. So the next one is ultrasound. Have you had an ultrasound yet?
I have.
Cool. So ultrasound is one of those things that most women want to do. You can see the baby, and that's awesome. What would be a reason why you would decline it?
I mean, there's something with they don't actually know the
Right.
reproductive ways that it would be
Yeah.
that affects the baby.
So the way that ultrasound got started in maternity care is an obstetrician, one of the first obstetricians who had, before he was an obstetrician, he was a metal worker. And they used the ultrasound to test the metal for weak spots. So he said, oh, well, if you can see inside the metal, then we could see inside this pregnant person's belly and see the baby and check. So they were like, oh yeah, sure, okay, let's try it. And so really, since then, it's been done. It's a personal decision as to whether or not you choose to do an ultrasound. Like I said, there's a lot of really great, you can see your baby, you can get anatomy. They have a great way of measuring your due date with the size of the baby. And so declining an ultrasound, the risk of affecting the baby with the actual ultrasound waves is pretty low because they do it only for, I think at the longest, it's about 30 minutes. But one thing you may not think of too is, so what information do you get from an ultrasound?
Depends on what kind, I guess.
Depends on what kind. Most of it is things like your due date based on size, anatomy, anything that could physically be wrong with baby. You can see some mutations, but not too many as far as, if there's a heart mutation, if your baby's missing an arm, things like that. So all of the things that you can find out from an ultrasound, can you do anything about them? Not one thing. So it could be, I've been trying to train myself to say things because my preferences, right? My preferences are different, but it could be that some of those things cause stress. So like you find out your baby has a heart defect and you're really stressed out about it. So then you're causing yourself stress for something that you can't do anything about right now. And in the future, hello, Erin. In the future, you will be able to change that. How's it going? Okay. Is Brianna here? She usually leaves me the key to lock up. Okay. So it's of course not something. Hi. Did you guys get the handouts in the email? Okay, so we're on. Yeah, I like the thumbs up. We're on ultrasound right now, so we're just a few down from the top. So anyways, it's just one of those things that you can choose to do, and there's not really going to be a whole lot of risks from it unless you find out something's wrong, and then it could be just stress, really. Yeah. And so managing your stress is huge in pregnancy because you are home for a baby, and your baby experiences all the same hormone levels that you do. So your stress level being super high is like ridiculously high for a baby, and that is the biggest concern with an ultrasound. Also, changing due dates is something that I want you to be aware of. If you have a later ultrasound, they can be less effective for guessing weight. And so also guessing size, they can be up to a pound off in either direction. And so changing a due date based on a late ultrasound is not recommended. And it's something that most OBs or midwives, it just depends on what they're looking for, but something to think about. So guest date. The next one is, this isn't a common test or technology or intervention, but it's something to remember that the first evidence-based birth handout that I gave you guys today is evidence on due dates. And it really just goes into what your due date is. I try to use guess date because, again, it's just an estimate. You have 2 weeks before, 2 weeks after. So what is considered full term? Do you know what week? 37 weeks, right. So 37 weeks is considered full term. After that point, you can have a baby at home. You're not considered to be preterm at all. And before that, you would be going to a hospital probably. Most midwives don't deliver before 37 weeks. But then as far as the hospital side of things, changing, this is why paying attention to your due date and knowing and being firm in it and not changing it later, because if you move your due date back, you're kind of cutting yourself off earlier for when you reach that 42-week mark. So many OBs, once you hit 40 weeks, they want to start talking about induction. And once you reach 41 weeks or 42 weeks, they're kind of like pushing on it to say, hey, you know, this is becoming unsafe. So what the risk of stillbirth at 39 weeks is the lowest, and then it slowly creeps up just a tiny bit as you keep going, and then at 42 weeks is the highest. So typically they won't let you go past 42 weeks, but the statistic says that I think it's something like 90% of women have their baby before or at 40 weeks, 5 days. So not a whole lot, you know, the chances of you going beyond that. However, once you reach 40 weeks, you'll get that phone calls and texts and people saying, is your baby here yet? Are you still pregnant? You know? And so I got to 41 weeks and I was like, what the heck is going on? You know, you just like, it's amazing how just a couple of days, it's like, what do they say? The longest week is the last week of pregnancy, which is like 375 days long, right? Because like, it's only 7 days, but you're like, hey, this has got to happen. You know, there's this shift. Yeah. That just like throws you off completely as far as the way that you felt. You get to that due date, and then it's like, nothing's happened. What do we do now, right? You do nothing. You just keep doing what you're doing. So your guess date. So a non-stress test is a test that they do when you go into the hospital. What would be the reasons for a non-stress test? It measures baby's heart rate that occur when heart rate changes that occur when baby moves in uterus. It's recommended when you notice a slowing of movements, or sometimes once you get up past that 40 weeks, they may say it's either a non-stress test or a biophysical profile. Have you guys heard of an APGAR score? Mm-hmm. So APGAR score, I didn't put it on here, but the APGAR is, you know, there's a set of 4 numbers that they do and they average them, and that sort of gives you a good estimate of the baby's well-being. So a biophysical profile is essentially an APGAR in utero. So they look at things like, the non-stress test is just via ultrasound and they're watching breathing movements, but the biophysical profile does everything from how much amniotic fluid is there, what is the baby's heart rate. You usually have a button and they'll be doing an ultrasound, and when you feel the baby move, you press the button, and then they look to see at that point if there's any changes in heart rate at all. So they still want to see the same reactive heartbeat that they do when you're in labor, or when they listen to the baby with like a Doppler. That's the word. It's amazing how having people listen to me will have words just fly out of my head. So yeah, the non-stress test. When mother's overdue or has high blood pressure, diabetes, or another medical condition. So those two are very similar. The biophysical profile is just a little bit more in depth. So if you reach 41 weeks, or if you reach 40 weeks and you start to have the conversation of, you know, okay, so what do we do if I reach 41 weeks? Typically what they'll say, and even my midwife, she said, you know, we'll have you do a biophysical profile. You go in at 41 weeks, you do a biophysical profile, and then that is valid for 1 week. So that puts you to 42 weeks. If you make it to 42 weeks and you're still pregnant, hopefully not, right? Then they'll do another biophysical profile. If that one is all clear and everything looks good, technically that can last you for a week. And so unlikely that you would go past 42 weeks. However, if you do, and I know Noel would be like, well, so, just keep on being pregnant with a baby comes. However, most OBs are going to look at that and say, okay, you've reached this point where we need to start looking at induction. We need to start looking at doing, but this is something you can ask for. Can we do a biophysical profile to make sure that baby is still doing well? And if so, what would be the medical reason otherwise to induce? If there's not one, why are we talking about this? So any questions on the top? These are the late pregnancy tests. I know you guys missed the first two, but you can come back. I'll send you the link to the video so you can watch the first couple. So common interventions, these are things that will come into play. The first question I have here is, what conditions influence the amount of interventions that are used? By the way, if you see page numbers on here in parentheses, that was just for my reference. If you do have it or want to borrow the book, The Birth Partner, what I'm referring to. So what conditions influence the interventions? Medical condition of the mother. So how is mother doing? How is her pregnancy? Was she healthy all the way through pregnancy? Were there any complications? The apparent well-being of the fetus. I love this because it says the apparent well-being. So it's always just a guesstimate, right? When baby's still on the inside, you can do things like listen to heart rate, listen to pulse, listen to blood pressure. But for the most part, well, you can't take the blood pressure of the baby while it's still in utero. So those are things that you're sort of, you're looking at averages, you're kind of guesstimating on. But how is baby doing? Baby's still okay. The training and philosophy of the caregiver. So this is going to be a huge one to remember, that it does affect the level of intervention that you may receive or be offered based on how your care provider has been trained. What is their norm? What is, how do they typically handle this situation versus how you would like it to be handled? The usual practices or policies of the institution and nursing staff, something we talked about. So hospital policy can affect your intervention rate, and the preferences of the mother. This one is last. I put a big star by it, and I'll remind you again, hospital policy never trumps patient rights. They may tell you it does, but it does not. So common obstetric interventions. We talked last week about pain medication and epidurals. The next one is intravenous fluids or a HEP lock. So what is the purpose of giving an IV? Anybody know what would be the purpose of an IV in labor? Mm-hmm.
Well, in case you have an infection, right?
Right. Right. So yeah, the IV fluids are typically given. They always usually want to do a HEP lock when you're in the hospital. IV fluids are given to stay hydrated. They are given to bulk up your blood pressure. If your blood pressure gets low, they can help to manage blood pressure. They can give intravenous medications. They can give intravenous antibiotics if those are things that are needed in your labor. One of the handouts that you got today is also the evidence on eating and drinking during labor. So this is a good one to read over, and it talks about the risk of aspiration. So the common reason that's given as why you need to have a HEP lock is because we need to be able to give you an IV if something happens and we need to do it quickly. So the other reason is that the risk of aspiration, which you can see the bottom left of the page. Since the 1940s, the use of general anesthesia has declined to less than 6% of cesarean, increased use of epidurals, as well as new techniques anesthesiologists use to manage stomach contents and keep a person's airway safe during surgery. In a large study of 45 million births, researchers looked at 129 maternal deaths that happened based on aspiration. So one death for every 1.4 million births based on aspiration during labor from having stomach contents. So these two things kind of go not completely hand in hand, but having an IV sort of ties you to that stand. And eating and drinking is really important. Actually, the next page, so the ACOG committee opinion, do you know what ACOG is? This is the American Committee of Gynecological, I think it's, yeah, obstetrics and gynecology. So this is on oral intake during labor. This is, any OB in this country is going by the ACOG recommendations. This is what they should be going by. So you guys in the hospital setting, ask the question, am I allowed to eat and drink more than just clear fluids during labor? I want you to take this in with you. And if they say no, I want you to hand it to them and say, why not? Because this right here is what they should be basing their practices off of. This was reaffirmed in 2015. So 3 years ago, ACOG says there is insufficient evidence to address the safety of any particular fasting period for solids in obstetric patients. Expert opinion supports that patients undergoing either elective cesarean delivery or elective postpartum tubal ligation should undergo fasting for 6 to 8 hours. So that's if you're choosing a cesarean before anything happens, or if you're getting a tubal ligation. So that's the surgery after, where they tie your tubes. Adherence to a predetermined fasting period before a non-elective surgical procedures is not possible. Therefore, solid foods should not be avoided in laboring patients. Okay, so this is a really important thing for you to have, because I don't guarantee you, but just ask the question when you go into your next appointment and say, am I allowed to eat and drink during labor? So you can read these into a little further, but these two pieces are sort of on the research and the statistics. And like I told them earlier, if you haven't explored the website Evidence-Based Birth, I want you to go do that, because their blog has like 25 to 30 different articles. You can type in anything that you're interested in learning more about, or that you have questions or want to know the actual statistics on. And there's pretty short but very informative pieces in there about everything. So HepLock and IV fluids are, the benefits obviously are that you will be able to be hydrated without having to eat or drink. The risks being overhydrated, not overhydrated, what is it called, edema. Disadvantages of giving IV fluids include fluid retention. An IV line is inconvenient. IV lines can sometimes infiltrate, which means they actually break the blood vessel and then it's absorbed into the skin or the tissues around it, which can be like bruising and painful. Alternatives to consider to IVs: offering food and drink during labor, and to keep the vein open so the caregiver can give an IV if they need to. So that's HepLock. Any questions about IVs? So the next one on here is fetal monitoring. So this is something that varies widely in obstetric care, and what kind of fetal monitoring your care provider will use. Most midwives use the Doppler, and so they're going to listen during a couple of contractions, and they want to hear the heart rate go up during contractions and then come back down to normal. And it sort of will always have a little variation. It should. As far as, someone's at my door. As far as fetal monitoring in the hospital setting, you know what that looks like. It's got the two little circle things, and they've got a big piece of Velcro that you wrap around your belly. There's external, internal, and wireless. Brookwood, I'm not sure if they have the wireless yet. I've heard that they maybe have a couple. That could be something you can ask about if they are okay with, if they have available an external wireless monitor for contractions, because you want to have free range of motion. But the other thing to ask is, can we do intermittent monitoring as opposed to continuous monitoring? So continuous being all around the clock. They want you to be on the monitors. There are some risk factors that will indicate you need to be on continuous monitoring. But for the most part, you can always, you should always have the option to do intermittent. And you also in that situation, yeah.
Hey, question. With the wireless monitoring, is that usually what goes on the baby's head?
That is internal monitoring.
That is. Oh, okay.
Okay.
So all you have to do is check in and walk out.
Okay.
But if you do walk out, then walk out. So just make sure if you have to do a trip.
Right. Okay. Cool. Okay. Thanks, Brianna. So what you're asking about is internal monitoring, which is where they put like a bulb catheter inside between baby's head and the wall of your uterus. And then they also put like a scalp probe on baby's head. And that is different than the external fetal monitoring. And then external fetal monitoring is different than the wireless. The wireless is like about this big, and it has like a bump on it and a few little like electrodes that come out, and it just looks like a big sticker, and they stick it right on your belly, and it does a pretty good job of monitoring contractions. Sometimes they'll still want to do intermittent, but there is a really great blog post from Evidence-Based Birth. I did put it in here. This is the one-page handout on fetal monitoring, which gives a brief types of and what is the evidence on. But the blog post on this, her most recent post on fetal monitoring, I definitely recommend you guys go and read that one fully, because it's a good thing to have knowledge-wise to come in and say, basically it doesn't really decrease the chances of your risk of C-section to have continuous monitoring. It actually increases your risk of C-section, because they're being proactive, but they're also looking at heart tones and taking them and saying, there may be something wrong, when really if you just give it more time, it's still reactive. But yeah, that one again, and this is something that is outside my scope as a doula, but from reading the research, it's something that you still can come in and say, I want intermittent monitoring, or intermittent usually means 15 minutes out of every hour. But, if you say no or yes, right, say both sides, but you can always push that back and ask them, can you come back in a little bit? I have a good rhythm. Or asking for the option to use a Doppler intermittently with intermittent monitoring. Do you have a Doppler? Is there anyone trained to listen with a Doppler who can come in and help for the time being? So what are the purposes of electronal fetal monitoring? Caregiver needs an accurate measurement of the intensity of contractions. The nurse or midwife cannot be with the mother continuously or frequently. So as a reason for fetal monitoring, that's an interesting thing to think about. If you receive Pitocin, you will be on continuous monitoring. And when there are doubts during labor about the fetus's well-being because of prematurity, small size, meconium-stained amniotic fluid, or possible lack of oxygen, such as low blood pressure, then you will probably be put on monitors more continuously. So the disadvantages of electronic fetal monitoring, your movements are restricted. Sometimes this can mean that more attention is paid to the machine that's monitoring instead of to the mother. Interpretation of the monitor printouts is extremely complex, and even experts can disagree about what different heart rate patterns really mean and when intervention is necessary. So this is why I say, even for you guys, you might want it. Good information, but to read the full article and see what she says about all the different reasons why electronic fetal monitoring can actually sometimes increase risk if it's continuous.
If you're looking for something, you'll probably find
Exactly. That's exactly right. If you're looking for something, you'll probably find it. And then internal monitoring requires breaking both bag of water. So that's what you were asking about. They have to break your water to put an internal monitor in, which I have not attended a birth where there was an internal monitor. I know that they're not as common for low risk pregnancies. The other disadvantage is that it only measures the fetal pulse, but cannot detect whether the fetus is experiencing a shortage of oxygen. So when cesareans are done solely because of electronic fetal monitoring tracing, so the pulse, babies often show no signs of having been oxygen deprived. For this reason, attempts to confirm the findings of electronic fetal monitoring are sometimes used. So that's the fetal scalp stimulation test. So you see how it's like, that's what just the uncertainty. The only thing you know is the baby's pulse. You can't tell if they have oxygen deprived. So if they do a C-section based on, these heart rate trends. So as long as you're still within the range of normal, even if it's on the low end, you probably still have options in time. So the fetal scalp test it's a simple test. They press or scratch on the baby's scalp during a vaginal exam. If the baby is in good condition, his heart rate will speed up with stimulation. So it's like they poke the baby responds. That's essentially what a fetal scalp test is. Yeah, like, so what are you doing? What is the purpose? It's to check whether baby is still tolerating labor. The test is medically indicated anytime fetal heart tones are non-reassuring. So if you hear that fetal heart tones are non-reassuring, they may want to come in and do a fetal scalp test. And that could be something, if you have non-reassuring fetal heart tones and your care provider is coming in saying, okay, baby's heart rate doesn't look good, we need to do a C-section. In that case, you could ask, can we do a fetal scalp stimulation test? Is that a possibility? So that could be an alternative to immediately going to a C-section. Alternatives to consider, relying on EFM alone, so that's electronic fetal monitoring. I keep getting stumbled over that word. Relying on frequent listening to the heart rate, or relying on the EFM plus fetal pulse oximetry. So that would be looking further fetal pulse oximetry. Fetal scalp sampling have been induced. Okay, so those are the same thing. Artificial, so the next one comes into, also, so induction is the next line. There's a link here if you go to the actual article and click on it, but basically if you go to evidence-based birth, you can also just type it in. So this is evidence on inducing labor for going past your due date. There was a recent study that sort of, I don't know how to say, it sort of like blew everyone out of the water. It was called the ARRIVE study, and what it said was, induction at 39 weeks can reduce your rate of stillbirth. However, there was a lot of limitations on this study, and a lot of them were not presented up front in the way that if something makes headline news, they're going to like give you the main points, right? But they don't really tell you what's behind, unless you actually go read it. So this piece right here, the evidence-based birth, I actually have met 2 women recently whose doctors wanted to induce at 39 weeks because of this study. And the reasoning is just, it doesn't really make sense because there are a lot more things you can do that can reduce your chance of C-section, more so than inducing at 39 weeks, okay? So this piece right here, I want you guys to go to this link and read the article about induction and going past your due date. So on the topic of induction, here are some that you may be offered. Some of the self-help methods, you remember the oxytocin bucket exercise. So all the ones that these are going to be the group of the alternatives to all of these medical induction methods. So you have like nipple stimulation. You have having sex, prostaglandins, cuddle time, intimacy, all of those oxytocin inducing. So those are going to be, most of those are going to be the alternatives to any of these further down methods of induction. So stripping the membranes, have you ever heard of that? No? Yes? 2? That happened to you twice? No, you said. Oh, okay. So stripping the membranes, for a long time, for some reason, I thought breaking your water and stripping the membranes were the same thing. So it's not, it's a little different. stripping the membranes is where they go inside your cervix and they strip the amniotic sac from the wall of the uterus so that it sort of like pulls it away. It doesn't necessarily break the water, but a lot of times it will break the water because they're doing so much with it, right? So stripping the membranes usually does not actually start labor, but it may hasten ripening, thickening, and thinning of the cervix to make it more ready. It also is a pretty painful process to have someone go inside your cervix when it's not dilated. She's like, yeah. Yeah, it's just one of those things that they're like, oh, it's going to be not that bad. And then every time I hear about it, it's like, that was the most terrible thing I've ever experienced. Artificial rupture of the membranes, AROM. This sometimes speeds or augments labor if it is timed correctly. So you may see something, prom is not the dance you go to. PROM is preterm rupture of membranes. So if your water breaks, or spontaneous rupture of your membranes, which is ROM. If your water ruptures before you begin labor, that's considered PROM. If it's before 37 weeks, obviously that would be one of those situations where you go, they have medicine they can give you to stop contractions. But there are several things you want to pay attention to if your water breaks. It's color of the fluid. Is it clear, or is it gold, or is it brown, or does it have chunks in it? If there's anything in it besides clear, take note.
So you want it to be clear.
You want it to be clear. However, if it's not clear, it's not terribly concerning, but you do need to pay attention to take a picture. That's what I always say. Like, take a photo. Your midwife is going to ask, or your OB is going to ask, what color was it? Were there chunks in it? Or was it clear? Did it smell? Did it smell like anything? Or was it a no smell? Like, it just didn't, you can't really tell what it is. How much of it was there? Was it just a little bit? Or was it like, you're running down your leg, right? And then how much, when did it happen? So if your water breaks, check the time, because those are the questions that you'll be asked. And let's see. So the clock with your water breaking is always mentioned, always comes up. I think they mentioned a little bit here on the failure to progress. So the failure to progress is also, it's more than just after your water breaks, but this is sort of touching on the normal length of labor in general and how it's hard to judge normal with labor, because you know what's not normal, and what is an average, but as far as your water breaking and being on a clock of 24 hours or 48 hours, that's something that you continue to ask those questions. Is mom okay? Is baby okay? I'd like to keep laboring, as long as you're still having productive contractions. And then so the reason that you have these time clocks is something called Friedman's curve. So it says 1955, a physician named Dr. Friedman published a study describing the amount of time it took 500 women to dilate during labor. Although this study was published over 60 years ago, it still served as the basis for how physicians defined normal labor until recently. So what your care provider may say is that you have to progress 1 centimeter per hour, or it's like for a first-time mom, 1.2 centimeters per hour. For a second-time or third-time mom, it's like 1 centimeter per hour for the first part of labor, and then for the end, it's much quicker. But there's, it's all relative. I love that they say it's like 500 women. It's not for
based on a big study.
yeah, yes, exactly. So for labor to be abnormally long, 4 to 6 hours of pushing is considered long. But yeah, And she's like, what? Much longer than that. But yeah, this one is a good one to read over. And I know I said this, but a lot of these, there's a longer piece on them if you go to the website. These are just the one-page short printouts. So did you guys get the part about this page right here? Can you see? It's just a bunch of boxes. So there's a page that's just got a bunch of things listed down the left side, and then at the top it says brain. And so the purpose of this is for you to go through either while we're discussing them, I guess I should have said it when you got on, or or later when you have a chance. You know, of course you'll be able to ask me questions later, but to go in and spend time to think about each one of these. What are the benefits? What are the risks? What are the alternatives? So that you have the opportunity to go through it. And then anything that you have holes in, we can talk about if you have questions about them. So that's why I put this in here and why it's blank. Okay, so AROM. The next one is, the other risks. I want to find this because I want to make sure I don't skip over it. Vacuum extraction. One of the risks of rupturing the water before, here it is, disadvantages of AROM. Frequently it does not speed labor. You increase your risk of infection, obviously, because you now have a broken bag of waters. You're removing the protective cushion, so contractions can be worse because there's not that extra fluid to cushion them. And malposition is the biggest one. Well, also increases your risk of cord compression and prolapse. But malpositioning, because if your water is not supposed to rupture, if it wasn't ever going to rupture until your baby's born, there's probably a reason for that, because it gives baby a little bit of space to turn. And so rupturing the water can not allow baby to have the space it needs to actually do the turning that it needs to do. I forgot last week, but remind me if I forget again. I have a few Instagram videos that are really short, like 15 seconds, that are really great examples of that rotation, where you can actually, it's a hands-off, where you can actually see baby turning before it comes out, if you want to see them. If you're on Instagram, I'm happy to send them to you so you can watch them later. But I just started looking through and found some really good ones. But point being, you know, it's a really easy intervention to say, you know, I can just break your water if you want, and it'll help things go faster. But there's just this whole host of other things that can not go wrong, but if it's not meant to happen, you know, there are benefits to having your water being intact for as long as possible. Unless it breaks on its own, then in that case, of course, it's meant to be. Alternatives to consider: refrain from breaking the bag of waters. That's pretty much, yeah. Use other methods to check fetal well-being. So prostaglandins is the next one. Prostaglandins are hormone-like substances produced by the body that can help to soften your cervix. Semen is a prostaglandin that the man's body makes. Some others that you may hear are Prepidil. This is a gel that's applied to the inside or outside of the cervix with a syringe. Cervidil is a tampon-like device that contains the hormones, that's placed in the cervix, in the vagina, behind the cervix, or behind the cervix. And it gradually releases prostaglandin over about 12 hours. The next one is Cytotec, which is a pill, a small tablet that's either placed inside the mother's vagina behind her cervix or given to her by mouth. There is a lot of research coming out about Cytotec that it is actually not indicated for use during pregnancy, and has caused a lot of different problems with fetal demise and otherwise. So more research on Cytotec, but there is no research on it for pregnant women. It's one of those things that they started using, and then anyway, so Cytotec is look into that one. Not a great idea, especially for something that you can't take out. If you take it orally, there's no reversing it. Is the baby moving?
Yeah.
Oh my God. And then of course the next one, so prostaglandins, if a lot of times they won't induce without your cervix being favorable meaning it started to soften, it started to move forward. So that's when those prostaglandins are used to sort of get you ready to be induced. And disadvantages. Sorry?
There's not any studies to back up.
Not for Cytotec. It's one of those things that if you look in, I told you like for vaccines, go read the inserts. If you read the insert for Cytotec, it's like contraindications, pregnancy. And yet it just is used so commonly for, not as much anymore, but it's one of those things. Once people start really noticing and saying something, then
Yeah.
people catch on. But so disadvantages of induction. Medical induction usually includes more interventions for safety than does spontaneous onset of labor, such as electronic fetal monitoring, IV fluids, and so on. Because the woman is hospitalized before her first contraction, she often becomes hungry and tired sooner, meaning that if you come in for an induction, even if you've eaten beforehand, checking in, going through the whole process, if you get induced, you're hungry and tired sooner, and if you're being induced, you're probably have less of a chance of having free eating and drinking during labor. So that's sort of like a perfect storm for being too tired and hangry to want to push a baby out. So non-medical reasons for induction is usually convenience, routine, and mother's discomfort. Medical reasons are, I lost my place. Medical reasons, high blood pressure, HELLP syndrome. Large baby is not a medical reason for induction. That's another one of your handouts. Macrosomia, evidence on suspected big babies. Even with gestational diabetes, there is still no evidence that supports induction for large babies. And most of that reason is because, coming all the way back to ultrasounds, the further you get in pregnancy, the less accurate ultrasounds are. Unless you have a severe case of gestational diabetes, it typically still, the statistics show that the baby size is just not usually ever big enough to, and in all the years of pre-Western medicine, if you think about the variables of like the size of the baby and when the mother goes into labor and the size of her pelvis, it all sort of, most of the time, works together and comes at a point where the baby will still fit through your pelvis. That's just the way that nature made it to happen. The risk of dystocia of the hips, where the hip opening, the pelvic inlet is not big enough to let the baby come through, is like 1 to 2%. But if you look at the statistic of when they diagnose pelvic dystocia, it's a lot higher than that. So it's another one of those situations where reasons doctors give. So next we have, what would be the reasons for medical induction? I just stated a few. Pregnancy is prolonged, so caregivers disagree about when pregnancy has gone too long. This is something that you'll be in constant conversation about once you start to get to that 38, 39, 40. It'll come up more and more. Some offer induction at 39, 40, or 41 weeks, but most agree statistically the risk to the baby waiting beyond 42 weeks are greater than the risk of inducing before that time. So 42 weeks is like the upper limit. When medical problems such as continuing the pregnancy might harm the baby or the mother, for example, high blood pressure or diabetes, when baby is not thriving, so you have arrested growth of the baby, When you have the bag of waters has been broken for a long time and the mother has tested positive for group B strep, those two together sometimes can be a reason for induction, but just having your waters broken, you can usually push it. When the mother has frequent herpes outbreaks, so herpes lesions is sometimes a reason for induction. If you are not having an outbreak and you have them regularly, then that would be something. Prolonged pre-labor and the cervix is firm, in which the case the use of prostaglandins may be appropriate. So if you never really get a favorable cervix, and that would be, of course, if you're getting cervical checks regularly and you're saying nothing's changing. Your cervix is not a crystal ball, so it could always change quickly, right? So some of the more, I didn't put a page on here, some of the more less commonly used interventions, episiotomy. You know what that is? Yes, we saw that. We talked about it. Episiotomy is a surgical cut. So purposes of an episiotomy, this gets me, to speed delivery by 5 to 10 minutes. If the baby appears severely compromised, but it's like 5 to 10 minutes, yeah, worth it? To reduce pressure on the baby's head, he's like, no. If baby is premature, has other problems, to enlarge a very tight vaginal opening when necessary to allow for delivery. It is very rare that the vagina will not stretch adequately. And to allow easier placement of forceps. So forceps are a vacuum delivery, vacuum extraction. Those are commonly used when baby is low in the pelvis, but not, once you get to the pushing phase, or like a shoulder dystocia, if you have a shoulder dystocia, you know what a shoulder dystocia is, where the top shoulder gets stuck under the pelvic bone. Episiotomy will, if no episiotomy is done, there's only a 30 to 60% chance that the mother's perineum will tear. However, research indicates that tears are almost always smaller and quicker to heal than the average episiotomy. So this is my image or example for episiotomy. So you have a cut like this, which would be your surgical episiotomy cut. And when it comes back together, the chances are that, actually the other good example I'll use, when it comes back together, the chances are that it's more likely to come apart. But there's also this. So if you try and just tear, right, it doesn't always work. But if you put a small tear and then try and tear, it's going to go a lot farther. So the other risk of episiotomy is that it'll tear further than, he's like, oh, sorry. It'll tear a lot further than they really intended for it to. So those are the disadvantages. Alternatives to consider, the caregiver can simply forego an episiotomy. So like I said, these are less common, but it's something to note, to speak with your doctor about and say, what is your rate of performing episiotomy, or I choose to not have an episiotomy unless medically indicated. What would be your reasons, medically indications for performing that procedure, right? I'm really thirsty today. So then vacuum extraction and forceps delivery, sometimes episiotomy is to facilitate those. I'll go ahead and show you my pelvis.
Right.
Y'all, I'm really excited about this. So, baby, okay, here's the first example. This is the ischial spine. You guys see that right here? This is the ischial spine, these little guys right here. So baby coming down your station, you remember your station example? I'll have this with me next week too, so you can see it in person. But your station is going to be where is baby's head in relation to the ischial spine. So LOA is like this, like that. Let me see. I need to get a big rubber band for her so that she stays in the fetal position. not meant to go through a pelvis. I know. Babe's like, one fly. So vacuum extraction or forceps delivery would be like babies all the way down where you can almost see, this would be considered close to crowning, right? So baby's head is visible, but not coming out, or labor has arrested and their contractions are not happening. And even if you have Pitocin or augmentation of labor and things aren't progressing, that usually would be the only reasons for a vacuum. Now our arm's stuck, here we go. So then you have that turn. Usually the bottom shoulder comes out first, and then the top shoulder. When I did this at home, it worked great. And now she's getting stuck. And they come out. And then the example, the reason that I got this one specifically is that it moves, right? So the hip squeeze. So can you see like the opening of the pelvis, right? You see the inlet. I'll show you guys this from that direction in a second. So when you do a hip squeeze, you're squeezing, the point is to kind of, I told you, find the hips in the back, and you're going to be pushing up and in. So when you do a hip squeeze, you see what happens to that pelvis? It gets just a tiny bit bigger, right? So this is the pelvis. When you do the hip squeeze, you're finding the crust of the hip bone, and you're going to be pushing up and in. So when you push up and in on both sides, you see how those ischial spines kind of go away from each other just a tiny bit? So it makes just a little bit of space. It's not a whole lot, but it could be enough to where, first of all, it feels better because you don't have pressure down there on those spines. But then the other thing that it does is open up the entire inlet. And then the reason that a upward, forward, over position for birthing is better than lying on your back is for the same reason. So when you lie on your back, what happens to your pelvic? So you see, here's the front of it. So when you lie on, I'm trying to use my shirt so you can see the back. So lie on your back, and then your pelvis closes just a little bit because the weight of your legs, which is pulling down right here, is going to pull down like that. So you're actually closing your pelvis just a little bit. And I think the ratio is like 30%. It can get up to 30% wider. So like when you do a squat and your legs are pulling outwards like this. So if you're lying on your back, it's going to close off just a little bit from the weight of your legs pulling down right here. Yeah. So that's the, and then like the hip squeeze, the counter pressure. Counter pressure is putting pressure like here. And really that's not, this bone right here, the coccyx is also a mobile piece. This is not anatomically correct here. It's not fused. So when you give pressure on the back of the sacrum, it can also do the same thing. It releases that pressure, but it also kind of like, it can move just a little bit to where you're getting that relief because there's not, if something's pressing from the inside and you push back, it sort of pushes it back where it is. And those bones will move around a little bit. I had a broken tailbone when I gave birth to my first son, and I didn't even notice it because of not from the birth, but because of something that happened like the year before he was born. And it just, what do you do for broken coccyx? Nothing. You can't do anything. So, but the good thing was like the endorphins of labor, I didn't even notice it. It didn't bother me at all. So that's the example for the pelvis. And then let's see if we can get her to cooperate this time. I did this all day yesterday. I was like, look at my pelvis. So LOA, did I do it facing this way? So LOA is like this. So she's looking back at your right hip, and then they go through the pelvis. So I got that floppy arm. And you're going to see the rotation. But I'm not holding on to it right either, so you can open it up, right? And then they come out this way. They typically come head up. Sunny side up would be like, you ever seen an image of a face presentation? Where there's like, it's a really interesting, I'll see if I can find one to show you guys next week, but like it's called Sunny Side Up, where the baby actually presents face first instead of like the top of the head first. So they're just like looking out at the world, right? Anyways, It's kind of a weird. Okay. So vacuum or forceps extraction would be like babies down through the birth canal, and then they need to get baby out quickly. That'll do that. Forceps purposes, deliver baby more quickly. If mother is not able to push effectively, so if you have any kind of spinal pain relief with no feeling, and you can't, she gets too tired, can't push, that would be one reason. Another thing to think about, so I attended a birth one time and I thought back on it, and I was like, well, why didn't they just use, vacuum or forceps? Because the baby was so high up that she didn't even make it to crowning. So it'd be one of those things, it's like, that could be an alternative to a C-section if you make it past, head is down through into the birth canal. That could be one of the things, an alternative to a cesarean. Disadvantage, okay, and then another thing to note, and I say this just because it's a common misconception. So forceps, the way the forceps work, there's not actually a way to clamp down all the way, right? There's a lock point where they close most of the way and then lock, so they can't put too much pressure on baby's head. They used to not be like that, so they would have injury from forceps being used too hard, but that's been a while. Some interesting movies about the history of obstetrics if you ever want to watch them. Alternatives to consider: directed pushing, pushing in positions that enlarge the pelvis, such as squatting with support, with or without support, the dangle, or lying flat on her back and pulling her knees up. So that would be why, if lying on your back, and when people stand on either side and pull your knees back, it has a similar effect as it does to being in a squat position, but still working against gravity in that sense. So what happens immediately after delivery? We sort of talked about some of this. I didn't go into, I don't know, do you guys, how much information do you feel like you would want about late pregnancy complications? These are things that the rest of active labor, I read through it and I started to put it in here, and then I said, I don't want it to be, yes, you know what I mean? Because for the most part, they're not like birth trauma or injury, low blood sugar, drug effects, breathing problems. A lot of the complications that occur after baby is born can often be remedied by having baby on mom. So low blood sugar, things like temperature not being right, putting baby on mama's chest, even if they want, any newborn procedures that need to be done can always be done. I saw a picture the other day of a baby getting resuscitated, and baby was lying, instead of lying on a towel and having a roll underneath its neck, the baby was lying directly on the mother's chest, and the mother had her hand underneath its neck. And it was a really cool picture to see, because it had the series of, the baby came out, they put the baby on her chest during the procedure, where mom was just sitting there waiting, and then as soon as they took it off and they were like, oh, the baby first cry, and her face was just it was amazing. But anyways, the point being, a lot of the, medically indicated for them to take your baby away, and this would always be something, of course, you'd be asking questions about, but for the most part, asking, can you do that while baby is on my chest? Can you do that while I'm holding my baby? Because the benefits of that most of the time far outweigh the risks of taking them to do it somewhere else. And there's really nothing that can't be done on your chest, unless, of course, you need IVs. So immediately after delivery, who cuts the cord? You guys thought about that? You doing it? You doing it? Oops, somebody got locked out. I don't know what happened. So who's catching the baby? Yeah. Yes, that's awesome. Baby warmth assessment. that is taking the baby's temperature, any of the things that, like weight. Midwives are usually really great about giving you that birth, what do they call it, the golden hour, where you have uninterrupted time. In a hospital setting, a lot of times nurses don't think about it. They want to do their job. They want to come in and do the things they need to do and get on to the next person. But it's always something to say, you know, we'd like to wait. We would like to not do these things right now, and wait until the first couple hours have gone by. I sent you guys the articles on eye ointment, vitamin K. There's not one on hepatitis B. Overheated rebooting. Okay. So the purpose of the eye ointment, did you read about that one? The purpose of the eye ointment is
That's if you have either gonorrhea or
chlamydia, right? So that's to prevent infant pink eye due to infection. Benefits would be they don't get it. Risks being you're putting an antibiotic in their eye the day they're born. And if you don't test positive for any of those things, right? Vitamin K is for clotting. The risks being bleeding internally or bleeding externally if you have any kind of procedures. Like really the only one they do immediately is the newborn heel prick. Circumcision would be the only procedure done on babies immediately after birth, unless there's complications that require further surgery, some heart issues and things like that, they will require it, but for the most part. So vitamin K. And I actually found another article on vitamin K that was the safety, where it's like it's the same as you see with immunizations, which is there's not a lot of safety research done, even though this is something that has been done for a while. And then hepatitis B, I don't know why I put that on there, besides the fact that these are things that happen usually, typically immediately after birth. They come in and they want to do eye ointment, vitamin K, and hepatitis B in the hospital. I don't think that midwives give routine vaccinations. You go to your pediatrician for that, if you choose to do so. Skin to skin, benefits of skin to skin. You know what the big benefit of skin to skin is? Or the several of them?
or the bonding.
Pressure is on. Yeah.
Bonding or it helps the milk.
Mm-hmm.
Okay. Do you think that's maybe?
Temperature regulation. So babies are not good at regulating their own temperature for a little while. So being close to you and your warmth helps them to feel warm. They can get it from birth partner too. But your warm skin helps to keep them warm, helps them to regulate, and also even like your heartbeat. Putting them right on your chest, they can feel your heartbeat, and it's amazing how you'll sync up. You know, women sync up on their cycles, right? So babies still kind of getting that homeostasis to work for them, and so being on you as much as possible during the first until you. I think Guyan didn't wear clothes for like 10 days because I just like would put on my over wrap and stick him inside there, and he had on the diaper, and that was it. My mom's like, "This baby's gonna freeze sweat." No, he's not. He's on me. So skin to skin. The other benefit is the microbiome. So you're feeding his microbiome with the things that are there that we can't see. The Vernix helps to kind of pick that stuff up. And so the next, I think, bath is a question mark, but breastfeeding is immediately, usually within the first, if not in the first 20 minutes, in the first 2 hours, you should have a good latch. Well, next week we'll talk a lot more about breastfeeding and some of the specifics. But that's something that takes support. And if you haven't already, I definitely recommend checking out a lactation support meeting, even if you don't have baby yet, so you know where it is, you know how to get there, you know what time it is, and put those things in your calendar so that if you need to go to them, you don't have to go looking for it when you're stressing out about breastfeeding. Okay. I think that's one of the best things that I did when I was pregnant. My midwife was like, you need to go. Unfortunately, there's not an in-person La Leche League group here in Birmingham. working on that. But there are groups through St. Vincent's and Brookwood Hospital, and there's a group on Facebook, I think it's called Mom's Best for Breastfeeding, and it's got the Birmingham, and actually I just shared a post on my Instagram too that has the link to all of the Alabama breastfeeding groups, and some of the ones that are within Birmingham are through St. Vincent's and Brookwood. But they have really great meetings where there's an IBCLC there in person, and it's just invaluable to either know them, just ask questions, make other mom friends, all that kind of stuff. But breastfeeding takes support, and it takes, we'll get into it more. I love breastfeeding. It's one of my favorite topics besides birth. So first bath is something that could happen with immediately after delivery. A lot of times, like you saw the video, they want to rub the baby, get all the vernix off. Midwife probably won't do that, but a lot of care providers do, and nurses want to clean the baby. So he's saying, no, we'd like to keep the baby dirty. It's not dirty, right? It's just vernix. And then rooming in. So rooming in is now becoming the norm. It didn't used to be. And in some places you still see, there's a hospital in Florence that's boasting their brand new big nursery window. And it's like, I don't need that window. Yeah, baby's going to be in my room. So that's another thing, unless there was a reason to take the baby for anything, it's even still, dad hopefully would be able to go with the baby for those purposes. But yeah, I'm gonna wait just a second and see if they come back on maybe for like a few minutes before I start cesarean delivery, because this is like the not really fun part, but
Yep. It's supposed to be right.
this is the one where it's like, do you guys have any questions?
I have a random question.
What's that?
My sister told me, she ended up having to have an emergency C-section.
See the air quotes?
Yes, I don't, there's thought, yeah. But is there a point when you're talking about when the baby's down far enough, the baby's down too far to where
Can't do a cesarean?
yes.
Once the head is out. So usually they can always, that would be a question that's good to ask Noel, but to ask your care provider and find out, because my answer, I'm pretty sure, is that once the head is out, you cannot do a cesarean. That's why shoulder dystocia is such a scary thing, because you can't do a cesarean. And once the head is out, it always is like, oh, the baby's gonna choke, because it's like you're, clothes around their neck, but they still are getting blood from the placenta at that point, since they're not fully born yet. But it's almost impossible to get the head to go back inside and to pull the baby out. However, that would be something based on station. So based on where their head is, according to the ischial spine, so your care provider would judge, how far is the baby descended. So if your labor slows down or arrests to a point where baby's station is not changing, but your contractions are still strong. Does that make sense? So like if your labor still seems like it's progressing, but the station is just not changing at all, and you're never making that downward progress, that could be an indication for a cesarean. But in that situation, that could be something where you say, let's look at baby's position. It could be a malposition issue. Maybe baby is not moving because they're, if they're turned the wrong way, they're rotating, but if you think about how this works, right? So your spine comes like this too. So if baby's this way and they're trying to rotate this way, it could just be that baby's malpositioned, and so that's why they can't drop. So trying to get baby to turn back around, right? So, but that's, those kinds of things are so hard to tell because you can't see the baby. So unless they come in with an ultrasound machine in the middle of labor and look and say, we know the position of baby, or the other thing is spinning babies, to have a professional who's schooled in spinning babies help to move the baby. But yeah, it's usually, I think, once baby's head is born, you go back to cesarean.
Well, and spinning babies on that note, because right now she's on this side
Mhm.
with her head down.
Mhm.
And Noel was saying, look up spinning babies if you look it up. If she doesn't go to the left side before labor, the labor will just be longer because she'll take time to get
to get there. Yep. That's a lot of times why you have non-prodromal labor, is positioning.
Baby's just moving again.
Baby's just moving. Yeah, trying to get
Well,
back
what
on.
way does she turn on the pelvis?
So LOA would be like this. They can turn anyway. While they're still in, it depends on how far engaged. So your cervix is usually like here. So how far engaged if baby is down pressing on the cervix, but that's why inversions are really great, because what inversions do is pull, so you're inverted, right? So baby drops down just a little bit, and then they have space to move around. And so you're pulling off the pelvis. And when you come back in, they can kind of settle into a better place or a different place. Some babies are very stubborn and don't really move that much, but things like a rebozo. So like I was saying, I didn't bring a scarf this week and I meant to, but a scarf that you can wrap around your belly and you stand behind her and you just do like this, hold on both sides. And it kind of just gives that little like wiggle enough. So if you do an inversion and do, it's called shaking the ankles. And you can also do it on your hips in the back to where the rebozo is like, it just kind of covers from like your tailbone to your lumbar and pulls around, and then you just shake it like this. And it kind of gets just a little bit of movement so that like a vibration will help things to be loose.
Yeah.
But yes, spinning babies, inversions, and mild circuit. How many?
32.
There you go. I mean, hi again. We've just been kind of chit-chatting. So Sly, every time I went in to the doctor, he was on the left side in perfect birthing position. And then every time I would leave the office and go home and lay down, he would move back to the other side of being on the right side. So it's not uncommon at this point for them to be moving a lot still. Definitely the left side is great, but just because the baby's not in the correct position doesn't mean they're not going to be born. It just, like she said, it means it'll take a little more time to kind of work into that position. So we just went over what happens immediately after delivery, which most of those things, since you guys are not first-time parents, have been through a little bit. But the biggest thing being, I don't know, there's not really one big thing, but if you guys want to come back through the video, and we'll have time to in our prenatals to talk. So I was saying this is my least favorite part to talk about because we don't love cesarean delivery, but we do want to know what your options are in the case that happens. So look around. Let's say all three of us women here were pregnant, right? 1 in 3 women giving birth end up in a cesarean section. So that means one of the 3 of us could potentially end up in a cesarean. Why is that? Currently, it's because of a lot of reasons. You can't pinpoint it on one thing in particular, but we want to still be prepared for this situation in the case that it does occur. So we're going to talk about ways to have a family-centered or a gentle cesarean section in the case that it is not an emergent cesarean in the sense that you don't have time to talk about it. If you do have time to talk about it, here are some things. When you make your birth plan, when you sit down and put it together, you definitely still want to include a cesarean plan and discuss it with your doctor because you want to preempt the fact that you will be whisked away and have this traumatic cesarean experience because it's common. So who is present in the OR? You will have the option to say, of course your partner will be there. Do you want to have a photographer? Do you want to have a family member be present? If you want a doula present, you check with your care provider first and say, this is something, if I end up in a cesarean, I would like to request that my husband and my doula be present. Of course, I can take photos, but my primary goal is to focus on mom. But that is up to you to secure my place. I can't raise my hand and say, hey, I want to be there. Can I come in? And they're going to say no, right? So you have to present that. Pain management. So in a cesarean situation. If you have the Heplock, or there's time to put in an IV, if you don't have one previously, you will get an epidural or a spinal. Unless it is a situation where you have to be put under general anesthesia immediately and the baby taken out, you should have the choice to say, in this sense, no extra relaxing drugs. So sometimes they include synthetic opiates along with the anesthesia to make mom feel relaxed. There's other things, I forget, not Valium, but some of the benzodiazepines that can just give you that like chill. You know, if you're really stressed out and anxious, that's one thing, but a lot of times those drugs can be so intense that after the cesarean, you're passed out for hours because they just gave you so much of the medication. So having the discussion pre-situation. In a cesarean, sometimes you have your arms strapped down. It is common to have your arms basically out and strapped down to the table because of shaking, and because you're not totally numb from, you know, you're not under general anesthesia and you're in a surgery where they have to use a scalpel to cut into you, but you have the option to not do that. So asking to have one arm free or to have neither arm free, you know, neither arm strapped down, those will be things that if it does come up, you would say, you know, just because they're doing something doesn't mean that it has to be done. So bringing up the conversation beforehand. Drape options, you have a clear drape or a drape to be lowered so that you're not just totally separated from the entire process. I know that it's a lot more common to have clear drapes so that you can see. If you don't want to see everything that's going on, you can have the drape lowered to the point where you can at least see the baby being pulled out. Environment options such as aromatherapy and music. Aromatherapy I got from a birth plan. I'm not sure about that in the OR situation since it is a sterile room. But music and shop talk. A lot of times, you know, if a doctor is doing something and they're just chit-chatting and saying, you know, whatever they want. So to request that you not have, they call it shop talk, kind of like if you were at a car shop, right? And then the other on that, to have them describe the events to you, to tell you what's going on as it's happening so that you don't feel like you're not a part of the process. Vaginal seeding. Has anybody heard of vaginal seeding? So we talked about the microbiome, and microbiome exists on your skin and your breast milk from the foods you eat, and the flora and fauna that exist in the vagina. So one thing that they can do if you do have a cesarean is to request vaginal seeding before you go into OR, and essentially all they do is they take a piece of gauze and they insert it so that you get all of the good stuff from inside your vagina where the baby would be passing through, and taking that into their nose and mouth and eyes and ears and all over their skin. And basically what they do is they just like rub it down on the baby. Seems kind of weird and kind of like, why would you do that? You know, but studies have shown that babies who have vaginal seeding have a similar microbiome, a similar diversity of microbiome to babies who were born vaginally. So it sets them up for success as far as having those good and bad bacteria present to get them started right. If you're interested in more information on cesareans and how they can affect later in life, how having a cesarean can affect you later in life, there's a movie called Microbirth. It's just like a just over an hour documentary. Pretty interesting. The first 10 or 15 minutes are a little bit post-apocalyptic, so just don't let it get to you. If you get into the movie, it's a pretty good one. Pictures or video. Do you want pictures or video of the operation or what's going down? And then skin to skin in the OR, you know, all of these things, if you were to end up in a cesarean, it's something that you just, you can't, birth plan is an exercise in learning, right? It's not that you're making a plan and you're expecting it to go this way. But because it's an exercise in learning, knowing all of these things and having these discussions, at least in presenting, you know, your preferences to your care provider, will be an opportunity for you to have that discussion and say, these things would be really important to me. You know, I want to make sure that I'm not being looked over here, and that this, you know, to just give yourself a chance to set yourself up for success with a birth plan. Recovery and rooming in, a lot of times back to the relaxing drugs. So if you're in recovery, it's different with a cesarean section, as in the sense that you don't go back to, you leave the labor and delivery, and before you go to postpartum, you're in recovery. And a lot of times in recovery, they don't let the babies come in. And that's something that I've seen a couple of moms who requested rooming in because they were like lucid enough to be able to hold, they couldn't actually hold the baby, but their partners were able to hold baby in recovery. But it can be a really difficult, I mean, you know, if you're having a baby, you want to have the baby with you, and it can be very upsetting and emotionally challenging when that baby is not there. So bringing that up to be that it is important to you. You can really easily have a cesarean that is a satisfying birth experience because you were prepared for that, even if you don't want to end up there, right? Again, this part's hard. So what would be the common reasons to have a cesarean? Let's go to knowing the non-medical reasons. So this is non-medical. Belief that the non-medically indicated cesarean is as safe or safer for the baby than vaginal birth. So I think we know that that's not correct. And a lot of care providers these days still sometimes default to that. A deep fear of labor and vaginal birth in the mother. It's actually called tocophobia. So this one is tough because remember when we talked about pain theories, and also about tracking your tigers. So if you are absolutely terrified of labor or absolutely terrified of a cesarean delivery, I should turn my phone on silent. It can actually be, you know, that fear can be something that actually holds you back and takes your labor to a place that, you know, you're not able to let go. Right? You're never really able to accept the fact that you're in labor, so we want to address those. That's one of the reasons for a non-medical cesarean. Fear of incontinence or pelvic floor damage caused by vaginal birth, convenience, and inadequate hospital facilities. So like labor and delivery is full, which these days in Birmingham doesn't happen. I would say that was one of the ones that doesn't. Medical reasons for a cesarean birth. Emergencies include prolapsed cord or a hemorrhage in the mother, placenta detaching from the uterine wall can be one reason for a cesarean. If you should have, it's not uncommon to have bleeding during your labor and to have like things like bloody show, and actually like sort of like period heavy. When you wipe, you continuously have, you know, some kind of if you are filling a pad within an hour and you're changing the pad every hour and it's totally soaked, that's too much. And you should be contacting and saying, this is not normal. I'm worried about the amount of blood that is happening. Arrested labor. Now this is, arrested labor comes to the article I gave you, which is failure to progress is commonly heard as, or like incompetent cervix. So I hate the term. But basically this means abnormal position or presentation of the baby, inadequate contractions, a poor fit between baby's head and the mother's pelvis, or a combination of these. So these are all, like I said, all kind of things that we were talking about spinning babies when you guys were rebooting, about how getting baby in the right position, sometimes pre-labor or arrested labor could be just due to the fact that the baby needs to get in a better position. And this is the biggest reason that I say movement is a common thread, because if you're moving and you're, even if it's uncomfortable, it does not feel good to move around and your body is telling you, this hurts, this doesn't feel good, why are you doing this? It's still good for you to move during labor, because you moving gives baby a chance to move. As you change your, bone structure based on how you're standing or sitting or squatting, your baby is going to be more free to move around and change positions as well. Problems with the fetus, fetal intolerance of labor, breech presentation, not a reason necessarily. It just depends on who your care provider is and how much they are willing to work with you on external versions, how to move the baby, chiropractic care. You've got all kinds of options if baby still presents breech. And then, of course, if you want more information on breech, if you reach that point, we'll address it more. But breech is just another variation of normal, and unfortunately, the art of breech vaginal delivery is fleeting, and not a lot of care providers know. I think Noel might do breech delivery. Pretty sure she does, actually. You haven't asked her? I think she does. I'm pretty sure she does. But it's one of those things that, common reason for a cesarean. So then problems with the mother, serious illness, which can include heart disease, severe gestational diabetes, preeclampsia or injury, a genital herpes sore. So just like I mentioned earlier, that having a genital herpes outbreak or common outbreaks can be a reason to plan a cesarean. It can also be a reason to have a cesarean. Unfortunately, if you have a herpes lesion, it's not safe to have vaginal birth, so that is a reason for a cesarean. Previous cesarean delivery. Now here's a sore thumb. This is a major reason in the US for cesarean deliveries. If you think about it, like, how are you ever going to get to have a second baby if your rate of initial cesareans is so high, and also you don't allow VBACs? How are you ever going to have it? So a previous cesarean is not a reason to have a repeat cesarean. It just requires more work and it requires more fight, but it is not impossible. So the VBAC rate has plummeted over the past decade, and even though the risks of VBAC are very low, with the right doctor and hospital, a VBAC is still possible. So what to expect? Preparations for surgery. The hardest part of a cesarean, I think, is waiting. You've labored, you've been laboring, you've made the decision to have a cesarean, and now you wait because you have to get prepped. You have to have an IV with fluids, you have to have the epidural, you have to have, if you don't already. And emotionally, you're kind of in the in-between of preparing yourself for, it's attending, and I'll say this too, attending an ICANN meeting, if you guys have a chance. The next one is actually on Tuesday, October 2nd. It is at their Retreat Day Spa on Overton Road. This one I think is about placenta accretia. It's the placenta accretia is where the placenta, you've had a previous cesarean, the placenta grows into the uterine wall. So there's the birth team required to have a placenta accretia delivery is something like 30 people, 25 to 30 people, because of the risks. It's such a high risk situation. But if you think about the high rate of cesareans, the rate of placenta accretia is increasing, and it's a pretty serious problem. But ICANN meetings are a really great resource and a really fun, another one of the groups in Birmingham to meet other moms and get connected and have a resource for knowing people before and after who have experienced this. I love going to ICANN meetings. I've never had a cesarean. I felt really awkward the first time I went because I was like, I don't know if I should be here. But it's their goal is to inform and to help prevent not only repeat cesareans but primary cesareans. So it's an informative place to be. So preparations for surgery, you probably receive oxygen, pulse oximeter, all of the things that go along with a surgery. So risks for a non-medically indicated or elective surgery, this is what you don't always hear. So if you have an emergency cesarean, obviously the risks are more heavily probably related to mom and baby and keeping them healthy and safe. Risks for a non-medically indicated cesarean include common surgery risks such as infection, hemorrhage, bladder or bowel injury, recovery complications, incision complications, scar tissue, abdominal adhesions, and problems with future childbearing. So, you know, it would be amazing, but it would totally surprise me if an OB, before they had, you know, offer a cesarean, say, okay, this might mean that you will have, you know, I mean, just like this host of risks that they typically will just skip over. And so anyways, okay. Do you guys have any questions about all of this stuff so far? Next to last class. Ryan, hi Ryan. Hey. No questions? No questions? You always got more time. You got one next week. Yeah, so your homework here says do some research. This is taking you back to evidence-based birth. If you have a little bit of time, or as you go through the end of your pregnancy, you can fill out this, or at least go through it and talk through and make sure you understand. If you don't go through and write everything down, at least go through and talk about these things. And on the ones that you don't know, put a star so that next week we can touch on them and make sure you have that full picture. Yeah? You guys good over there? Cool. Okay, so next week here, next Saturday, October 6th, 4 to 6 p.m. And hopefully, I think my friend Joy might be coming down for this last one. We'll see. We'll see. Cool. Well, I will see you guys soon. Sound good?
Feel better.
Yes, feel better, Erin. Yeah.
All right.
I'm saying hi.
Say hi.
Hey, Ryan.